Okay, let's dive right into the high-stakes world of biliary and pancreatic surgery.
Section 1, Anatomy to Pathology. To master the life and death complications we'll be covering in this explainer, we first have to really lock down that anatomical foundation.
So here's a fundamental question to start us off. Where exactly do the common bile duct and the main pancreatic duct unite? Is it A, the lateral border of the duodenum, B, the anterior surface of the pancreatic neck, or C, deep within the head of the pancreas?
If you guess C, you hit the nail on the head. They unite deep within the parenchymal substance at the head of the pancreas to form the hepatopancreatic ampulla. And why does this matter clinically? Well, think about it. A single stone impacting this specific shared terminal channel blocks both systems. It triggers both ascending cholangitis and acute gallstone pancreatitis at the exact same time. It's true dual-organ chaos.
And this brilliantly illustrates Courvoisier's law. Because the distal common bile duct is embedded directly within that pancreatic tissue, even an early-stage carcinoma in the pancreatic head is going to compress it. This leads to painless, progressive obstructive jaundice and a palpable, non-tender gallbladder. It's a classic absolute giveaway pointing to malignancy, not gallstones.
Section 2, Managing the Gallstone Gauntlet. Let's look at the everyday pathologies and see exactly how we escalate treatment as the clinical picture worsens.
All right, picture this. A 34-year-old patient is scheduled for an elective laparoscopic cholecystectomy. But a preoperative MRI reveals a 1-centimeter stone in the mid-common bile duct. What's your move? Option A, do you perform an ERCP first? Or option B, do you take them straight to surgery?
The answer is A. For a preoperative stone, the gold standard is a two-stage strategy. You go in with the ERCP first for stone retrieval and then follow it sequentially with the lap chole. But keep in mind, if you discover that stone intraoperatively, the whole strategy shifts to a single-stage laparoscopic common bile duct exploration.
Let's pivot to a special population case. A 4-month pregnant patient presents with severe biliary colic. What's the safest management strategy here? Do you go with option A, early open surgery, or option B, wait until after delivery?
Well, it actually depends entirely on the trimester. Your absolute first-line approach is conservative dietary modification. But if symptoms become totally intractable and surgery is mandatory, the second trimester, right at that 4-month mark, is your exact ideal surgical window. You really want to avoid the first trimester because of teratogenic risks, and by the third trimester, the enlarged uterus makes laparoscopy technically prohibitive.
Section 3. Navigating Surgical Complications. We are escalating the clinical narrative right into the operating room where you have to make split-second decisions.
Here's a high-tension surgical scenario. You're doing an open cholecystectomy and accidentally cause a 2-millimeter partial lateral laceration to the common bile duct. Good news, there's zero tissue loss. What is your immediate protocol? Option A, place a drain. Option B, Roux-en-Y reconstructive bypass. Or option C, primary suture repair.
It's option C. You want to perform a primary end-to-end suture repair over an indwelling T-tube. A massive reconstructive bypass, like a Roux-en-Y, is total overkill for a small, clean cut. You reserve that for complete transections. The T-tube here is perfect because it decompresses the biliary tree and acts as a scaffold to stop any fibrotic strictures from forming.
So the crucial point here is the 3-millimeter rule. If you have an aberrantly cut duct under 3 millimeters, it likely just drains a single subsegment and you can safely ligate it. But if that duct is 4 millimeters or greater, it's draining multiple segments, and structural repair is absolutely mandatory.
Now let's fast forward to post-op day 10. A cholangiogram reveals an 8-millimeter retained stone in a T-tube tract. The correct intervention here is the Burhanna technique. It's a highly specific percutaneous sequence. Step 1, you've got to wait 4 to 6 weeks for a fibrous tract to mature. This prevents bile leaks. Step 2, remove the T-tube. Step 3, advance a choleduchoscope down that mature tract. And step 4, extract the stone under direct visualization.
Okay, quick diagnostic question for you. A 38-year-old patient undergoes a successful therapeutic ERCP, but shortly after she develops severe, constant epigastric pain radiating straight to her back along with vomiting. What just happened?
If you said post-ERCP acute pancreatitis, you're spot on. This happens in approximately 5% of procedures, which actually makes it the most common major complication of ERCP, especially in young, female patients who just had therapeutic sphincterotomies.
Section 4. Emergencies and Palliative Care.
We are moving into the final and most critical phase, life-threatening sepsis and terminal oncology.
Let's look at a terrifying, rapidly progressing emergency. An elderly diabetic patient presents in shock. Right upper quadrant pain, a fever of 103, and blood pressure tanking at 90/60. Ultrasound shows gallstones, but crucially, it shows gas within the gallbladder wall. What's the diagnosis?
This is emphysematous cholecystitis. It's a highly virulent variant driven by gas-producing anaerobic organisms, classically Clostridium perfringens. The presentation can often be masked by diabetic autonomic neuropathy, but because of localized ischemia, there's an extreme risk of early gangrene and perforation. This mandates an immediate, emergency laparoscopic cholecystectomy. There's literally no time to wait.
Now, what's absolutely fascinating here is the clinical escalation. We all know Charcot's triad: fever, right upper quadrant pain, and jaundice, which points to a basic ascending cholangitis. But when that progresses to Reynolds pentad, adding septic shock and altered mental status, you're looking at a completely obstructed supraurethral system where bacteria are just overflowing into the bloodstream.
So, if you have a patient with Reynolds pentad and a massive, say 1.5 centimeter stone, ERCP is simply too risky. The correct intervention? Immediate decompression via emergency percutaneous transhepatic cholangiography, or PTC. You have to drain the system externally, let the severe sepsis settle down, and delay definitive surgery for later. Let's transition over to palliative oncology with a highly specific mechanical question. You have a patient with advanced, unresectable pancreatic cancer, causing both severe obstructive jaundice and gastric outlet obstruction. You need to place stents endoscopically. In what exact order must you place them? Option A, biliary stent first, or Option B, duodenal stent first.
The correct answer is option A. That metal biliary stent must go in first. It's a strict, non-negotiable rule. If you place the duodenal stent first, it physically blocks your visual and mechanical access to the ampulla of Vater, meaning you can't get into the bile duct at all. Once you've secured that biliary stent, then you can place the duodenal stent, start pancreatic enzymes like creon, and do a celiac plexus block for true multimodal palliation.
So, let's bring it all back. Could missing a 3 millimeter detail in the anatomy really lead to a catastrophic surgical emergency down the line? Absolutely. Because the union of these ducts can cause dual organ failure, and millimeter-specific rules govern exactly how we repair them. Everything, literally everything, builds on that foundational anatomy.